Jessica, before you leave, I hope it's a quite long time before you get it. You said when he dies, we don't want that happening anytime soon. I do too. The title of the presentation, as you see, is Perfusion Techniques, Present and Future. I have no declarations or other conflicts to declare to you, and I'll get right into the presentation. I begin with the first successful cardiopulmonary bypass procedure, which Dr. Gibbon instituted successfully May the 6th, 1953. And this is a photograph of the procedure that day that he sent to Dr. DeBakey, proudly informing him of the accomplishment. Now, to begin with, I want to imply to you, there was a whole lot of innovation required, as you can see, in the beginning of our profession. This is
the patient, a sickly 7-year-old girl, is anesthetized and wrapped in a cooling blanket. Refrigerant circulates through the blanket until rectal temperature reaches 28 degrees centigrade. The cooling blanket is then removed. The patient is placed in a lateral position, and the heart and great vessels are exposed through a right thoracotomy. The right atrium is closed with a tangential clamp, while the atriotomy is sutured. The cava are released, restoring the patient's own circulation, and the heart takes over on its own. With the chest wall closed, the patient is immersed in a bath of water about 114 degrees Fahrenheit to warm her. In 35 minutes, her rectal temperature reaches 36 degrees centigrade, and she is removed from the practical, if primitive, Sears Roebuck cattle watering tank.
We've come a long way, haven't we? And the innovation had already taken place. If you think about this, they advanced from the ice water immersion tub to cool the baby to an insulating blanket. Here is another fun video.
In this extracorporeal circulation hookup, the patient is on the left, the Sigma motor pump for cross circulation is in the center, and the disposable bubble oxygenator is on the right. Operations were done under normothermia. The oxygenator reservoir is immersed in a water bath to control temperature deviations. Venous blood rises in the oxygenator mixing tube, enters the transverse debubbling chamber, and then into the final debubbling in the Helix reservoir in this 1955 model of the DeWalt Lillahei Helix Reservoir Oxygenator.
The water circulating you saw around the helical coil was to rewarm the patient and things like this. So there was a lot of work left to be done, and very quickly intravenous history was something that physicians had been working on for centuries, about 300 years. And you can see that Sir Christopher Wren used a concoction of wine, ale, opium, and liver of antimony. That's ground liver components, a metallic type substance they mixed and infused into dog veins. And then eventually in the 1880s, milk was used as a substitute for that. And eventually saline was utilized to replace milk. Thank God we live in the era that we do. The 1960 is a centennial year for cardiovascular perfusion. You see Nazi Zudi from Oklahoma City at Mercy Hospital with Modine Pierce, who was his perfusionist. I fortunately got to meet Modine a few times, and she was a very unassuming, quiet individual, at least in my experience. And I pay tribute to her today because she was the first perfusionist in the world to conduct hemodilution. And I listen to the women always say, where are the women on this program, this, that, and the other? Women were the most prominent figures in perfusion in the early days, and I have proof of that. But anyway, Dr. Zudi said of her, she dedicated herself so that millions would benefit, and ever was thus. The young child was 7 years old, underwent pulmonary valve stenosis repair. He was on pump 29 minutes, moderate hypothermia. And you note the term there, pay careful attention to this. Water in 2 new and clean garbage cans. We're still not there innovatively yet, warming or cooling, but the patient survived 3.5 years. He succumbed not due to cardiac illness. He succumbed to the development of Ewing sarcoma. And here's a tribute to Modine. She's sitting at the pump, operating a water bath system right here that was manufactured in Oklahoma City. And you see the garbage cans they were talking about up at the top left. They were insulated and clean, but one can contain cold water, one warm or hot water, and that's how they controlled the temp. And with regard to Modine, I'll quote Goethe, things which matter most must never be at the mercy of things which matter least. And I think that really describes her personality. The monumental impact, I won't educate anyone in this room of this conduct of cardiopulmonary bypass. Children and adults no longer had to procure 9 to 20. Nazi Zudi required 9 donors to be present the day of the operation, but they no longer had to do that with controlled hemodilution. And Jehovah's Witnesses here at this institution, and Dr. Cooley was prominent in the early development of hemodilution also. And there was a period where there was a little bit of conflict as to who was first, but he finally conceded that Dr. Zudi was. But anyway, y'all know the benefits of hemodilution and its impact. So the present time that we're in right now has lasted 35 years, in my opinion, from the 80s to today. And Gandhi probably said it best in his Civil War period that he endured. The future depends on what we do in the present. And I think that's very apropos. And I'm a major proponent of goal-directed therapy. I practiced perfusion for 42 years now, and probably the first 30, we in some ways flew by the seat of our pants doing what we always did and things like this, but we have brought more definition to what we do, and I think all of you would agree with that. And the future is now. And I still question, I see Dr. Livesay over here, we place patients on the pump and we don't perfuse the lung parenchyma. And I often wonder, why do we think patients struggle to be extubated or so on and so forth? How many times have you thought you're going to have a half-hour pump run and it turns into a 1 hour, 3 hour, or in some instances, a 5 hour pump run? And for that period of time, you never perfuse the parenchyma, and the bronchial circulation only perfuses 5% of the cardiac output normally to the airways and so on. So I would love to pick Dr. Livesay's mind and see if he thinks that's positive. The celiac trunk is another area that we're learning more and more about, and trying to perfuse the celiac bed is a challenge, but I lose sleep over renal failure. And I'm going to transition into that. Renal failure is what really agonizes me, for patients to have to transition to CRRT. And goal-directed therapy, you read, is highly emphasized with DO2 index and all of this, and I agree, but it's much more than that. It's customized care for disease-specific, organ-specific, patient-specific conditions. Our drug management is critical. If you wonder why people are going into acute kidney injury or those with chronic kidney disease that transition to a worser condition, vasopressor therapy and everything else just tears down everything that we've tried to do to preserve the kidneys. And then I'm a believer in preconditioning. If we could get there before the patient ever goes on pump, peri-perfusion conditioning for the post-pump period. And I don't think we emphasize that enough. And you see some of the equations here. I don't have time to go through all of this, but I highly have an interest in colloid osmotic pressure estimated. We used to have an oncometer in the operating room, and you could measure the colloid osmotic pressure of your prime and the patient, but somebody didn't think that was a good idea to continue, and it fell through the cracks. But I'm real interested in the actual versus predicted dilution rate, and you can see how we calculate this. And I calculate all this stuff prior to the patient entering the operating room. And here's blood volume calculations that are necessary to apply to achieve all the things that I wish in that regard. And the area of interest that concerns me is stage 3A and 3B renal failure primarily. I'm not sure that there's a whole lot I can do with patients that are in stage 5 renal failure at admission to the operating room. And then stage 4, I think you could describe this 3A to 4, you're trying to prevent them from progressing to the need of CRRT. That's my goal. And the renal bed receives 10 to 20% of the cardiac output, yet it blows me away how the kidneys reside in a world of near hypoxia. They sacrifice oxygen extraction for filtration. And if you look at this slide, I don't know if y'all can see it very well. The outer medulla and outer cortex have a PO2 ranging from 8 to 25 millimeters of mercury. Why is that important? It's diffusion distance of oxygen in the tissue bed, but if you look at most of your patients in renal failure, they're anemic. And if you don't have adequate blood transport, adequate blood flow, or hypoperfusion, I don't know that we can count on preserving the kidneys in this regard. If you look at pharmacologic management, I withdraw mannitol treatment on patients in stage 3A or greater renal failure. There was an article published out of this institution regarding cyclosporin A. It changes how I deal with patients that are post-renal transplant and presenting for cardiac surgery. The combination of cyclosporin A and mannitol, cyclosporin A potentiates the adverse effect of mannitol, and that was published right out of this institution. And in this case, it wasn't a cardiac patient. The patient was on mannitol. They withdrew mannitol treatment, and the renal failure recovered in this patient. So there's interesting things that we can learn here. And you see the histologic effect of osmotic nephrosis in the kidneys. And the top image is urinalysis with vacuolization that is very prominent from the renal failure. And I think that you can just zoom in on the fact that 50% of mannitol is excreted in the first 15 minutes, unchanged in its structure. 90% is recovered in the urine after 24 hours. However, in the presence of renal failure, the half-life of mannitol can be extended from its 70 to 100 minutes to greater than 36 hours. So I'm transitioning to albumin, and we have a present group of patients that we're monitoring. Anyone that comes in stage 3A renal failure, I'm infusing in the prime 200 milliliters of 25% albumin. And then once we induce cardioplegia with Dalnito, after I get the Dalnito removed, giving another 200. And then if it turns into a longer pump run, I subsequently give another 200. People criticize the cost of albumin, but I'm more critical of the cost of the prolonged ICU stay, hospital stay, and then the transition to CRRT. And then if you look at these numbers right here, this is just a sample of prime volume. IV fluid commonly at our institution is about 500 milliliters before you go on pump. Cardioplegia volume in the range of 1,280, that's crystalloid Dalnito. And that in turn translates to about 2,500. How many times, and don't anyone in the room deny this, have you gotten tied up multitasking, doing this, doing that? You intended to take off, let's say, a liter of ultrafiltrate, maybe 2 liters. And oh crap, you look over at the collection bottle and you've taken off 3. Dehydrating the kidneys is not a good thing. We do this in an attempt to restore hematocrit on bypass, but we walk a fine line in that effort as opposed to transfusing 1 unit. And I'm looking forward to the presentation later on washing packed red blood cells before you give them on the pump. I practice that as well, but I think that we have to be very careful how much we dilute our patients and then how much we ultrafiltrate. And you can see if you factor in Dalnito here, my calculated dilution rate is 36%. Without Dalnito, like if you're doing a beating heart support, the dilution rate is right at 20%. So these are things that we have to think about, and the hypertonicity and the effect of both your prime and the cardioplegia can have detrimental effect on the kidneys. This slide, I would just focus mainly on the filtration fraction. You can get this equation from Deb. I gave her the formula and everything, but that's just estimating how much ultrafiltrate you remove. This is a case example of a patient that I did. He began pre-op with a creatinine of 1.78, EGFR of 44. Over the course of 4 days, his creatinine rose to 3.17. I thought, oh God, we didn't accomplish our task here. And then in the 4 to 9 day period, he transitioned back to his near beginning creatinine and EGFR level. He did get a transfusion on pump, and he did get a transfusion between day 4 and day 8. You can see the crit rose, but he did not transition to the requirement for CRRT, and that's my goal. And I state at the bottom, give the nephrologist a chance. And I wish we had more of them at our meetings to educate us on this, but you can see the blood flow index, the MAP, and so on and so forth that we conducted on the patient. So, having heard about all of me you care to hear, I have a question for you that you can ponder. Is it CPB, or is it how we manage CPB? And I make an argument here that I think it's how we manage it, and the abomination of Dr. Gibbons' wonderful technology that has saved millions of lives is abused in the literature, and you would get depressed and not even want to go near the heart-lung machine. if you believe everything you read, but we're learning today after the discovery of the human genome and the more knowledge we have gained from mitochondria, mitochondrial diseases, and so on and so forth. I think the younger people in this room, hopefully when I need this procedure in 10 years, will have it all figured out because I haven't done that yet. Thank you. Have a great day.